I'm completely and totally fluent in illness. And I am just dumb in the world of wellness. Like, I have so much to learn about wellness as a doctor, which is so, it's just so strange to say out loud. But like, I think most people don't realize that dichotomy truly exists out there.
What's going on, everybody? It's AJ here at the Blue to Green podcast. So on this episode, I sit down with Dr. Quinn Snyder. Dr. Snyder is the owner and CEO of a ketamine therapy clinic. He's also a medical doctor and been in the medical profession for many, many years. And we sit down and we have a conversation as to what wellness looks like in regards to physical health, mental health, and what he's doing in the ketamine world. So we have a conversation that kind of talks about his origins of medicine and how he got to where he is now, and looking at the whole holistic approach to the human being, especially on the medicine side, on the mental health side with the ketamine treatment and stuff like that. And we talk about the journey of being in the medicine and out of the medicine and what a person can expect on a ketamine type based experience. I ask a lot of questions as to what the whole thing looks like, because I have a lot of questions about it personally, but I'm going to follow this episode up with going to his clinic and all that stuff and taking a look around, and I'll add it to it. This is not a commercial for his therapy, for his particular clinic. I just wanted to learn more about what the medicine is, learn more about Dr. Snyder. He seems very, very invested in his patients and getting people happy, getting people healthy, and making them a whole human being again. So thank you very much, everybody, for tuning in. We will put all of Dr. Snyder's contact information in the footnotes, and where to go for his ketamine clinic here in Arizona. And thank you very much for tuning in.
He threw some things out of the car right there. He's throwing some things out the passenger side. They're along the wall, the slow lane wall. 619, he's throwing still about the window. We got Bill, the marijuana coming out.
619, I copy Bill, the marijuana coming out of the window at 2328.
So, Dr. Quinn Snyder, thank you very much for making the drive down here. Let's go ahead and get started off, and I appreciate you for coming onto the podcast.
Thanks so much for having me. Really.
I already said I apologize. I'm not sick. I've just got this sinus thing that's going nuts with my allergies, so I apologize for that. But let's go ahead and get started. Let's talk about who you are, what your background is, and what led you down the path of what we're going to talk about today, which is that of ketamine and ketamine clinics.
Yeah, sure. No, glad to talk about it. I mean, I guess we got a little time to unspool here, so I'll give you the longer version about who I am and how I ended up here, I guess. So I grew up in Los Angeles, moved out from LA to the Phoenix area in 1994, went to Chaparral High School.
Okay.
So been out here a while, did undergrad at Duke.
Okay.
Took a year off at that time, ended up between college and medical school. I went to kind of explore stuff out in Europe. Explored whether or not I want to be a bartender, maybe for the rest of my life. Did not feel like that was the pathway for me, even though I loved bartending. I bartended in college and whatnot. Bartended in London for a year, traveled around, wasn't what I was looking for. Came back to medical school at the U of A Tucson.
Okay.
So was there for 4 years, and during that time, the initial part of it, I went into this thinking like, okay, I am going to go into integrative medicine. I'm going to look at medicine from a different perspective, not just the pure Western perspective, but also other modalities, and kind of bring them in. Spent the first 2 years kind of looking towards that pathway. I'm like, okay, I'm probably going to end up doing something a little more expansive than just regular medicine. Ended up studying under Andrew Weil a little bit while I was there, who is kind of like a world-renowned plant medicine expert, also faculty at U of A. Learned a lot, ended up going to India in the middle of medical school, studied some more plant medicine there, went with a friend of mine, went for a month, came back. By that point, that was like really the point of inflection. For whatever reason, I dove really deep into the world of just regular Western medicine at that point.
Can I ask you a question?
Yeah, go ahead.
When you stated that in the very beginning of you going to medical school that you wanted to go down the integrative path.
Yeah.
What led you to that to start with? Because most people don't go into it looking at a holistic point of view. And I apologize for cutting you off. I'm interested as to what initially got you there.
Yeah, no, so I don't mind backing up a little bit more, actually. You know, a lot of it came from my mother, to be honest.
Okay.
My mother really was always more on kind of like the woo-woo spectrum, let's say. And growing up in LA,
I was going to say probably had a little bit to do with that.
Definitely. There was a lot of that going on. And I remember my first real exposure to healing was actually out in the Pacific Palisades.
Okay.
we went out to the Palisades, and my mother knew a couple healers that were working out there that were also working with her at the time. And I ended up studying energy healing for the first time with them, and like moving energy and seeing how that translated into the world of healing.
Okay.
Which was fascinating. And that was kind of my introduction. But yeah, my mother really kind of like had this idea that, you know, I was more something on kind of that woo-woo spectrum, and maybe that would be the pathway for me. So she was trying to kind of expose me to some of those things. And at the same time, you know, my whole family is lawyers.
Okay.
Everybody's a lawyer in my family. My dad's a lawyer. My wife's a lawyer. My best friend's a lawyer. My dad, my grandfather, and my great-grandfather were actually in practice together at one point, all attorneys in Los Angeles. So not a lot of medical people, some here and there. But anyway, it just felt like very early on that the like healing was the pathway for me for whatever reason. And so yeah, I think I started more from that perspective, like I was going to end up that way. But then, yes, the pendulum really started to swing severely the other way. And then mid-med school, you know, started doing my clinical rotations. There's a big difference between the first 2 years of med school and the last 2 years of med school. The first 2 years, it's all in book, lots of exams and everything. And honestly, I think clinically it ends up being a lot more like theoretical. You know, you're exposed to this like, you know, what possibilities are out there for you in medicine, including integrative medicine, which I explored, you know, in those first 2 years. But then mid-med school started doing my clinical rotations. And I remember trying to find, where do I fit into this? Like, I just couldn't really find where I fit into it. And then I did a trauma surgery rotation, and I didn't fit in there either, but we did spend time in the ER. We spent a lot of time in the emergency department, and I looked around. I loved the chaos. I loved the fact that it was just so useful. I mean, people working in the emergency department are just so desperately needed. And what I realized was that the ER, oddly enough, is the paragon of Western medicine. Okay. You're not going to go see a homeopath if you break a bone.
You're right.
Or if you're
have a bullet
or
wound.
if your abdomen, if you have a bullet wound, it's like you're not going to go see the homeopath.
Right.
You know, you're going to go to the emergency department. Right. And I love being able to provide that like really definitive acute care. And that whole world, like I had just never really been exposed to. And all of a sudden, I ended up, instead of the world of the woo-woo, I was in the most Western form of Western medicine that existed. And I took to it, did residency, absolutely loved it. Spent my time in Philadelphia in residency, really rough and tumble kind of environment, honestly. Really fabulous place to learn how to do emergency medicine, truthfully. And then at that point, I started clinical practice, came back out here. I was 30 at the time when I became an attending. Started working at a facility not too far from here called Banner Desert, which, you know, and then I...
Were you there when it was prior to it being a level 1 or when it already was one?
I was there before it was a level 1 trauma center. So yeah, but even by that time, it was rapidly growing. When I first got there in 2010, our census was under 100,000 patients. The next hospital over, Mesa General, closed, I believe it was 2014, I think, when Mesa General closed. And then by 2016, Banner Desert had become the 5th largest emergency department in the entire country, and by far the biggest in the entire region.
Okay.
It's certainly in the state, obviously. But during that time, I became a partner in my physicians group, and I started to do data analytics. I started to do clinical operations. It made sense for our group at that point to ultimately sell our practice to a large private equity-backed contract management group. I oversaw that transaction. Some good things happened because of it. Some bad things happened because of it.
Business is business.
Private equity in the world of medicine, I am extremely skeptical about private equity being involved in medicine in general.
Okay.
Now having gone through that process, now having worked for a private equity-backed contract management group, I got hired after that deal to work for them. So I've been working in the world of corporate medicine alongside clinical medicine that entire time. Meanwhile, 2019 moves into 2020, and I'm overseeing the clinical operations of the largest emergency department in the state of Arizona, and also working in the ER, also working in the ICU, seeing just unbelievable things happen. I mean, this is, once in a lifetime
Sure.
kind of thing.
You're speaking specifically about COVID and the pandemic.
Yeah.
We can say it.
Yeah.
We can say it. We censor nothing.
So yes, it was COVID time.
Okay.
And it was terrible.
Okay.
It was terrible. I mean, anybody in medicine at that time was a mess. I mean, I knew people who died who were totally normal, healthy people on the front lines, and that's what it's like being on the front lines, whether it's in medicine or in war or whatever. But I mean, yeah, there are going to be casualties of that. And I got to see it up close. It was terrible. And so I ended up, when the pandemic started to evolve to the point where we were kind of coming to grips with it in a more comfortable way, where COVID all of a sudden was something manageable, which it still is obviously today. Sure. I started to look at other things that I thought were worthy of my time in medicine. And I was really drawn to the world of psychedelics, very much drawn to the world of psychedelic medicine, including ketamine.
Was this something that you had what led you down that path? Did you have a personal experience hearing stories? I
did, yeah. I had a personal experience with psychedelic medicines, including ketamine, yeah. And I found it to be incredibly healing. And it was something I really felt like I needed, honestly, at that time in my life, yeah.
I'm going to ask a personal question, and that's kind of like what I like. Was part of it dealing with traumas from working in the ER and working and dealing with emergency room physicians, nurses, everybody that works there are just as much a first responder as the police officer, the firefighter, or the paramedic or EMT that's out there on the road. You see the exact same stuff. The only thing that they see is it as a package as opposed to out on the highway. So with that being said, I've always been a big advocate of the fact that emergency room staff is absolutely a first responder and deals with the same sorts of trauma, and they see the same sorts of thing.
Yeah, and I mean, I appreciate that, by the way, and I think most emergency physicians feel very deeply connected to the first responder community at large. I mean, like, a lot of people don't realize that in level 1 trauma centers, there's so much overlap between emergency physicians and police and fire. And there's just this constant milieu of these various professions, and they all converge in the emergency department. And I've just always felt a special kinship with fire and police in particular, because we work together constantly. And I think there's a significant amount of mutual respect there. I feel very connected to what they do and the challenges they go through. And certainly in the pandemic, yeah, there was a lot of overlap there too. Yeah.
And I've been out of law enforcement when that was occurring, but just thinking back to my own personal experiences, and absolutely, it was particularly when there was a suspect who was now in the emergency room, who maybe they just did something horrific. And I don't want to stay on this topic for too long, but I just wanted to show the brotherhood and the kinship and all that type of stuff. And it was as professional as possible, but also how can we aid in the investigation in a way that is, moral, ethical, and legal.
Yeah, and sometimes those are difficult. It's difficult to manage that. And I think, like, there are boundaries there, in the ED, but I'll say personally, almost categorically, that I've always had incredibly professional interactions with police and fire, and there have never been any issues. And sometimes, yeah, there are like some lines that maybe somebody wants to cross, and it's like, you know what, that's actually not appropriate. I'm sorry, we can't do that today, and it's okay, and everybody just backs off. I mean, yeah, you see these incidents happen, like you've seen there was like a nurse in Utah who some weird stuff happened, and like obviously that was a terrible misunderstanding, should never have happened and whatnot, but yeah, I mean, I think for the most part, most people understand how to work together effectively.
Absolutely.
Yeah, I mean, we're all on the same team. We're trying to take care of people. We're trying to protect the public. Yeah.
A real quick question about your ER. You said that, you went through the first parts of your medical school, and it's a lot of theory and book and all that type of stuff. So was that your internship? I'm sorry, did you say, was it residency or internship? I want to be correct on the terminology because I don't know.
Yeah, no. So those terms, yeah. So intern year typically means like your first year of residency. It's a little nuanced there, but yeah, so intern would be your first year, and then residency as a whole means all of that experience together typically, yeah.
Your first exposure, I'll call it the exposure, to the emergency room, had you had anything like that in the first responder world, in any sort of adrenaline-laced, action-packed, junkie-type situation, or was that your exposure to it and was like, oh, I like this?
That was that my first experience with that kind of vibe? Yeah,
Yes.
it was.
Okay.
Absolutely. Yeah, I'd never seen that kind of thing. I mean, I'd never done an ambulance ride along before or anything like that. I'd never. Yeah, I mean, I was definitely drawn to that adrenaline side of things, and I think probably most fire and police feel that way too,
Absolutely.
right? I mean, I think there's definitely that element. Yeah, you get a lot of risk taker personalities in the world of emergency medicine. It's almost like a joke, everybody has some extreme sport addiction, kind of on the side. Everybody did something. For me, it was actually rock climbing, which may or may not be an extreme sport.
Oh no, it is. Absolutely.
Yeah. I mean, yeah, no, I loved it. I mean, I got to spend a ton of time out on Mount Lemmon in Tucson.
Nice.
It was quite the addiction back then. But yeah, no, I think a lot of people, are drawn to that in the profession, and that goes, and that's beyond just the docs, obviously, the nurses and the techs and everybody working in that department for whatever reason. Yeah, I think there is those moments of excitement that really kind of define a lot of the experience for us. Over time that changes, I think, and I'm sure it's the same for police and fire too. But for us, yeah, I mean, eventually it stops being something that you need or even want, I remember one night I intubated 4 people in a single shift. And I remember when just intubating somebody, I'd get very excited. I'm like, oh yeah, okay, I'm gonna put in the breathing tube, we're gonna get this save and whatnot. But I remember by the time that 4th tube came up, I just thought, wow, I really don't want to be doing this right now. I don't want to do
practiced
it again.
enough. Thank you very much.
Yeah,
I got it.
You do. You hit your limit. Yeah. I mean, that hospital, Banner Desert, is a pressure cooker.
Mm-hmm.
It is an absolute pressure cooker. I mean, it's the kind of place that, and I worked there for 14 years. I quit just a year ago, but when I was there for that long, I just realized when I stepped out of it, I was like, I can practice anywhere.
Right.
And I'm not scared of anything in the emergency medicine world, at least, which was a really incredible feeling. So yeah, I'm very blessed to have had that experience. And yeah, I mean, I think I ended up having, in that vein of this kind of extreme form of medicine, I guess, where there's this adrenaline kind of stuff. I mean, that kind of extended into the period of the pandemic,
Sure.
But that is also a path to burnout. That is a path to burnout. When you don't get any of that dopamine rest.
Yep.
You're constantly getting this boom, 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 one thing after the other, and your brain's never allowed to relax. And if you're never allowed to relax, there's just never any room to heal. And yeah, that's kind of what it was like in the pandemic, especially. I mean, I was just constantly on my toes, the hypervigilance and whatnot. And I think that kind of extended into this idea where people who I was working with, we're openly talking about our trauma.
Yeah.
Openly talking about, I talked to a doc one time. I remember we were sitting in the bullpen of the ER, and he just looked at me. He's like, I think I'm getting PTSD right now.
Really?
It just tore me up. And I was thinking, I'm like, yeah, I'm thinking to myself, yeah, maybe me too.
But unfortunately, we have a job to do when we can't focus on that right now, and we have to move on to the next patient that's going to die.
You have no choice. You got to
choice.
You got to keep moving. You're there. You're so inside it, and and it's weird to have that kind of insight where you're saying wow, this is happening to me.
I'm getting a little emotional right now. I didn't expect this podcast to be this emotionally charged, because I dealt with a lot of my own stuff as well, and I'm sitting here thinking about first responders, and again, I've already made the claim that, ER staff is part of that, takes on the trauma of other people and then has to suffer through and push through it. You have to absorb that trauma, compartmentalize it, and now move on to the next sick patient, law enforcement, whether it's the next suspect with a gun, fire department, the next dead child in a pool, whatever the case may be. So yeah, no, I kind of didn't expect this to come out, but I'm glad we're having the conversation.
Yeah, me too.
I'm glad it's heading this way. So yeah, no, it's powerful stuff. And also, how many times are doctors even regarded as having PTSD? Or even the thought, it's always other people. It's never nurses and again, the emergency staff and all that.
Yeah, medical professionals are terrible at self-assessment.
And self-care.
Yeah, and self-care. And that is something that's really struck me more recently, by the way, as I've done a lot more work with the first responder community. the first responder community is so far more advanced in the world of self-care than medicine is at this point.
Really?
Oh man, you would not believe it. The resources that are available to first responders who are such high value people. I mean, these are just incredible people who choose to serve the community. The resources that are available to them for their own personal wellness, and it's remarkable. I mean, they're the 100 Club, the Compassion Alliance. There are numerous organizations out there that have so many resources that they can help first responders with, and the culture. I'm just so impressed with the culture that I find in the first responder world. And in medicine, it's like it's just not the same. And I'm not sure why. It's like we might have just trained ourselves so intensely to act like we kind of just understand this stuff. And if we can rationalize it, then we must be able to work through it on our own. You know, and I think first responders have that awareness that obviously they haven't had that training in particular. So they're willing to give themselves over to it. But like, I mean, I've done presentations with like entire departments before about ketamine, about wellness, and it's just, the questions are great. They're just really attuned to this kind of stuff in a way that I find that medical people are not. Medical people are just reluctant. And I think this goes in the first responder world too. Medical people are a lot more reluctant to say that something is wrong with me, like to raise your hand, because there have been demonstrable consequences to people who have raised their hand. And I know that goes for the world of fire and police too. However, I know that's changing a lot more so in fire police. There's a lot more room for treatment and for dealing with tough issues, and I think it is changing in medicine, but it's just not at the pace in the first responder world. Yeah.
The one thing I will say is that I'm happy that now it is changing and there are more resources. This is my take on this, is that I think, and again, this is just all personal opinion, I believe that the law enforcement first responder world in that aspect recognizes the fact that they're broken and they want to get help, and they don't know what the help is or what it looks like. Whereas medicine, you guys are trained, much like law enforcement and fire, to be the help. But from a medicinal standpoint, did you receive any self-care tips when you were in medical school? No. Your body is connected to the mind, and you need to, exercise both, and, cortisol levels and stress or anything. I'm sure you learned about all that stuff, but not probably how it applied to yourself and your own self-care.
Not nearly enough.
Right.
I mean, we did here and there, and I think maybe that's what I was drawn to in the world of integrative medicine in particular. Like, I'd get some of those whispers, and I'd say, "Oh, well, that's cool," but my first thought was always like, "Well, how can I apply that to my patients?"
Yeah, you never.
How do I apply? Like, you never, like, I never really thought, okay, well, what can I do for myself? Like, and I'm a person who just like I like to just go. I like to keep moving. I like to go and everything, but yeah, I mean, I'm learning a lot about the world of self-care right now. And I realized recently was that I'm completely and totally fluent in illness. And I am just dumb in the world of wellness. Like, I have so much to learn about wellness as a doctor, which is so, it's just so strange to say out loud, but like, I think most people don't realize that dichotomy truly exists out there. And then, that's something I'm trying very much so to incorporate into my clinic.
Okay. Total body wellness, mental wellness, physical wellness.
Stuff far beyond just like, okay, because I mean, the first like axiom of what we're trying to do in our clinic, which is like, I maybe we should talk a little about the clinic.
I was going to say,
yeah. I don't want to go there until we're ready.
No. It's a beautiful segue into the mental health, into the wellness, because I first of all, those are very powerful words that you just said about, and we're self-aware of yourself that you didn't realize. And then I think it's a beautiful segue into what wellness looks like.
Yeah.
So to you and to your clinic.
Boy, what wellness looks like, it can mean so many different things to different people, and I'm really learning about that a lot right now. But so yeah, so the clinic. So what happened was, so yes, I ended up series of events. I was the chief medical officer of a clinic previously, a ketamine clinic. Made sense for me as a clinician to take ownership of that clinic,
Okay.
and now it's mine. And very proud that yes, I'm the CEO of this clinic now, and it's called Kadelyx Health, spelled Kadelyx. And thanks.
We'll get the information out there as well.
Awesome, thanks. Yeah, Kadelyx.
Of course,
It's short. It's short for psychedelics. You know, it starts with a K for.
Oh, I love it.
For ketamine, which is what we're going to start with. And yeah, there's a Y and an X at the end, and the Y is for tryptamines and psilocybin, and the X is for MDMA, because we're going to do it all. If it's safe, effective, and legal, we're going to do it all.
That is, I love that, what you just said. That's a very well thought out design in your logo. I love it.
No, we're doing awesome work. I mean, seriously, like when you see the kind of healing that can happen from using ketamine therapy for the treatment of anxiety, depression, PTSD, eating disorders, OCD, it is incredible. And I mean, I've seen a ton of my career, obviously, with acute healing, but this is different. And the gratitude that I've gotten from this is fundamentally different than anything I've ever seen in the emergency department. I mean, I've gotten more gratitude in the last year and a half of doing this than I have in, now 15 years of practicing emergency medicine put together, by a lot.
I'm pulling up some questions that I had specifically about the ketamine. I didn't want you to think I was being rude. You just mentioned a host of things that you've seen it help heal and all that. And I want to dive into all of it. The question that I have is that what is the crossover for a medical doctor now into the mental health side of things?
Oh, great question. So I think traditionally people think that, at least in the medical world, that the mental health sphere, it's like all the psychiatrists, it's like psychiatrists, like that's their thing. Nobody else touches it.
Sure.
But at the same time, ketamine happens to be a drug that is a dissociative anesthetic. So you have an anesthetic agent that has psychotherapeutic benefit. So then you start to develop the Venn diagram, okay? And on one side, you've got the psychotherapeutic stuff, and that's like the psychiatrists. Yeah, they're rocking it out. They do a great job. But then on the other side, you've got the anesthetic medication. So you're like, okay, you're thinking to yourself, well, anesthesiologists,
Sure.
of course, like anesthesiologists are great. But where those cross in the middle, that's emergency medicine.
Okay.
That's emergency medicine, because you're using an anesthetic agent for psychotherapeutic purposes. So a lot of people don't realize just how much of emergency medicine is acute psychiatric emergencies. People coming in with acute suicidality.
Sure.
And we see people who are severely mentally ill constantly in our practices. There's been a massive shift over the past several decades towards shunting a lot of those individuals towards the emergency department rather than psychiatric institutions or whatnot. So, and that may be changing, in some parts of the country, and probably will continue to change over the next few years, but we'll have to see.
I did hear when I had Mr. Ken Volkmar on here, we were talking about exactly what you just stated, and it has a lot to do with the fact that, don't quote me on numbers, please, but it was something like America used to have 500,000 mental health patient beds. Now they're down to like 35,000 across the nation. So we can't criminalize mental health because that just puts them into the criminal justice system. So what do you do with them? But that's not the conversation I want to have right now. But that's, unfortunately, it's getting pushed into the emergency rooms. Where what do you do with them?
You got it.
Now you guys are their psychologists and their psychiatrists and dealing with the mental health side.
We do our best with limited resources, and we're legitimately trying to help people.
Yeah.
And I think, it's interesting, like there probably is a lot of room for ketamine in the emergency department for psychotherapeutic purposes, but for the most part, my initial exposure to it was pretty much, it actually started out with pediatric procedural sedation. Like I've been using ketamine for 15 years now, and I was starting it with kids as young as 6 months of age with like complex lacerations, where you need time to kind of repair these lacerations. Okay. You give them ketamine, it's so safe, and you're able to do the repair, and then and so be it. But yeah, I mean, I've used ketamine on people as old as 87 years old. and everything in between. But yeah, in the emergency department, for the most part, it's used primarily for procedural sedation. But as a drug that appears to be the most potent anti-suicidal drug that exists, yes, ketamine should probably be used much more extensively in emergency departments. Okay. There is some research out there on it, but it deserves a lot more. But you're talking about an agent that can delay acute suicidality for at least 1 to 2 weeks just with one dose.
Okay. Well, how much is a dose? What's it?
It depends. I think for the kind of stuff the way we do it, the sub-anesthetic dissociative dosing, so to speak, is usually somewhere around 0.5 milligrams per kilogram.
Okay.
So 0.5 milligram per kilogram, usually administered IV, but it can also be administered IM, which most people tend to find as a more pleasurable experience, frankly.
Really?
Yeah.
As opposed to the IV style.
Yeah,
Does it just hit differently in the body? Or?
No, it's interesting. So IV, it's like, so the bioavailability, meaning like the amount that your body gets and is able to process without being metabolized, is 100% with IV. Like your body gets all the drug.
Okay.
With IM, very predictably, it's 93%. So it's pretty much about the same. And there's not really a lot of variability there. So like 93%, you're going to get 93% of that drug. But if you do IV, what happens is that it just kind of, the experience tends to like ramp up really slowly. And then by the end of the experience, when you turn off of the infusion, it tapers off pretty quick.
Okay.
A lot of studies have found that the side effects tend to be more with IV, a little more nausea, a little more agitation and whatnot. And truthfully, what I've found in clinical practice and what I've also heard from other people who are in the ketamine business is that invariably that if you have an individual, let's say, with a history of complex PTSD, often truthfully veterans, often people who've seen combat, what will happen is that they'll get that initial agitation, and instead of just going with it, they'll rip the IV out.
Really?
They'll just be like, I'm done here.
They don't want to face it.
Don't want to deal with it.
Okay.
IM, on the other hand, though, you're kind of committing to the experience.
Okay.
It's true. Yeah.
Understood.
You commit to the experience. And in addition to that, the contour of the experience is different. So typically 15 minutes after you receive the full dose of the medication, that's peak experience.
Okay.
So you'll be about 15 minutes into it, and then it's kind of like a slower taper off.
IM.
After, yes,
okay.
with IM, and it kind of it's like more of like a gentle landing.
Intramuscular.
So meaning forgive me, yes, direct. IV meaning it means directly into the vein, and intramuscular means directly into the muscle, and directly into the muscle means direct injections. Yeah. So typically that means the deltoid, the shoulder.
Gotcha.
So yeah, we typically do a 2-shot protocol actually. So we'll do an initial kind of like test dose / what we call anxiolytic. So a medication that will kind of like help calm your nerves a little bit, but it also allows us to see, you're going to sit well with this. You're going to have allergic reaction. By the way, I've never seen an allergic reaction to anybody using ketamine ever.
Really?
Never.
You've never seen an allergic reaction?
Zero.
Interesting.
And we've had over 700 clients. I have not once seen a single person have an allergic reaction ever to this medication.
No anaphylactic shock. No nothing.
Not even.
Wow.
Nothing close.
Amazing.
Close. The real risks of ketamine come elsewhere. Frankly, I mean, I think there's physiologic risks and then there's psychological risks, so to speak. Physiological risks, that tends to center more around the prospect of a couple things. Aspiration, like if you vomit, you get those food contents into your lungs. And what we do to prevent that, obviously, people just don't eat for 4 hours before the session. So we have you stop eating for 4 hours before the session, stop drinking for 1 hour before the session. So even if you do get nauseated, which, by the way, we pre-medicate pretty much everybody with nausea medication. Like, there's no reason not to. This stuff is so benign. Zofran. I mean, I don't know if you heard of it, but it's just like, it's so mild. It's ridiculous. It's like it's like water. So yeah, we'll give Zofran, and then we do the medicine usually, and that lasts. People are usually in the medicine usually about anywhere between 45 to 90 minutes or so. And
of the experience of when you just said in the medicine.
Yes, under the influence of the ketamine.
Okay, so you're saying it only lasts per that dosage that you're giving, that therapeutic dosage is 45 to 90 minutes. Interesting. Okay.
And then you come out of it, and then the experience is really bookended by two things. By the way, at the beginning. And then talking more about that like psychological safety element. At the beginning, to really do ketamine right, you really do need to engage in preparation work.
Okay. I was going to ask about that.
Like if you're going to enter a non-ordinary state of consciousness for the first time, or even if it's not the first time, it doesn't matter. Like if you're going to enter in a non-ordinary state of consciousness, if you put the time in to get grounded before the experience, prepare for the fact that you might feel like you're about to have an out-of-body experience.
Okay.
You know, and do meditation and breath work and whatnot, and also declaring an intention. Why are you here? What are you hoping to get out of this experience? Really, like asking yourself those questions, which, you know, can sometimes be challenging for people, you know, to help explore them.
What if the question is they don't know? They just know they need to be there.
Sometimes that happens.
Okay.
Sometimes that happens. But trying to at least explore that up front can often be helpful. But then on the back end of the experience is also probably the most important part, which is the integration work. So integrating what happened during your experience and bringing that all together. So yes, preparation and then medicine and then integration. Okay. So the integration portion can be done in different ways. And that can include, you know, having a therapist with you at bedside or a guide, somebody who's there, whose primary goal is to just unpack kind of what happened with the experience.
This is physically at the clinic with you?
Yeah. So
okay.
at our clinic, we specialize in guided ketamine therapy.
Okay.
So we have a guide who's with you the entire time, and our sessions last roughly 3 hours.
And I apologize. Like I want to know the intricacies of all this stuff. I'm very interested in this. Yeah.
Oh no, of course. Yeah, no, happy to explain. Yeah, a lot of people don't know the intricacies, and it's all very new, frankly. And I mean, there is an ample body of research now out there at this point. But I think what we've learned is that it's like, yes, you can do it the simple medical way where you're just getting your medicine and then you're walking out the door. And like we've heard absolutely wild stories of people who like have gotten medicine like that, maybe an intravenous infusion, and then like woke up and there was no one in the clinic to tend to them. Like people have de-accessed their own IVs and walked out the door after having gotten an anesthetic agent. I mean, to us, this is like bonkers stuff. Like we would never do this kind of a thing. It's so far afield for us. No, we try very hard to create a sense of psychological safety for our clients up front, to create the best possible, what we call set and setting for the experience. They talk a lot about this with psychedelic medicines.
Sure.
So set being that ideal mindset entering experience, which they found that people who are relaxed and are able to enter the experience in a way that is a little more calm and positive are more likely to have a better outcome at the back end if they do have that. And then setting, of course, which is something that I think a lot of people in medicine, Western medicine, have completely overlooked.
Okay.
Like to have an experience like this, like if you're in a room that looks like a dentist's office, vinyl, but not like this room, by the way. This is it's very cozy. I like it in here too. If it's cozy and warm and friendly, nice colors, nice vibe, like it totally changes the experience.
Okay.
If it's versus vinyl, chrome, and plastic, and disposables and harsh lighting and whatever, like that it doesn't have to be that way.
Okay.
And I think as an emergency physician, like it's something I tell people when I bring them into the clinic and I give them a tour. I say one of the best things about this clinic is that I didn't design it.
Yeah, I gotcha.
Had I designed it, it wouldn't look anything.
Be clinical and sterile.
Yeah.
Gotcha.
No, we had this really extraordinary designer. Her name is Esther Mathers, by the way. She's absolutely extraordinary designer. She put together this like absolutely wonderful environment that just feels warm. And I think people walk in and they just feel calm.
Sure.
Immediately. And I think that really accelerates the entire process for people's healing.
So you do the preparation work. Mm-hmm. Is there, say I book a date and time to go to your clinic. Is there some sort of work that you give them ahead of time to say, hey, do this, learn this, learn breath work? And I have a understanding of like the wellness and meditation. I have my own stuff I do, which I didn't 5 years ago until I realized how important self-care is. Is there, what is the leading up to the appointment with your clinic specifically?
Yeah, so we do. So we have a journey guide, has some details about certain things I can work on beforehand, but they also do have a medical intake, and we discuss some of those things in advance. of the appointment, of things that they can do to kind of help get themselves in a good headspace during the medical intake. But even beyond that, we do also have what we call some integration coaching that we can initiate prior to the experience. Something that I've found, something I've just found in my career, people just heal in different ways.
Yeah, absolutely.
People heal in different ways, and like not everybody fits into this nice, neat box where everything works this way every time. It just doesn't. And you have to kind of keep an open mind about how people are going to heal. So some people, yeah, they do walk into the clinic and they're just like, they don't necessarily want to engage in that breathwork and meditation. But all of a sudden, once they're drawn into that milieu and they start seeing the value of doing that preparation work beforehand, all of a sudden it starts to click. And so, yes, so trying to demonstrate some of these behaviors to them, obviously very, very important, and kind of help coaching them through it, like in the beginning. Yeah, and we do have clients who come in directly from therapists.
Okay.
So they'll see their therapist. Maybe the therapist is in a position where they've been working with their client for a while. They're not quite getting to the next step in terms of their progress. And they say, I think we need some ketamine to really start to kind of examine the root causes of what's going on. Because ketamine really does kind of peel away the layers of the onion. It kind of really helps open things up. And that can be, it can be very powerful, very transformative. I mean, the drug itself, by the way, I mean, for the most part, depression, anxiety, PTSD looks to be roughly 70 to 80% effective.
Okay.
Which sounds good. You look at it, you're like, wow, that sounds pretty good. When you look at it in comparison to your usual SSRIs, Paxil, Prozac, Lexapro, whatever, that typical class of medication, which are considered first-line antidepressants, those medicines are only about 40% effective. 40% effective. So like the system is set up for people with depression such that they're putting people on drugs that they know from the outset are more likely to fail than they are to succeed. And then you start to ask yourself, why are we making people suffer like this? Why would you do that to your own family or somebody? Why would you say, oh, you know what? Hang on. Let's try a couple different drugs that have side effects like weight gain and sexual dysfunction, have a black box warning on them saying you have increased suicidality in the first 2 weeks of using it, that have a more likely to fail than succeed rate. And we're going to do that for 6 months before we even think about doing other stuff. And you're like, what is this? Like, why are we doing this to people?
I mean, I think it would be safe to say that there's a lot of big pharma involved in that. And it'd be safe to say that there's a lot of doctors that don't have the holistic understanding of what medicine and wellness is, and just, I was taught to prescribe this and just prescribe this. Would that be a fair assessment?
I think it has a lot to do with it. I think it definitely fits in neatly with the model as described. And I think there obviously are plenty of medicines where that certainly works well. I mean, there's a whole host of medicines where taking them every day for whatever reason. Yeah, I mean, it's like for whatever it may be. I mean, I take a statin every day. I love it. I'd like to keep my cholesterol down.
Gotcha.
But yeah, I mean, certain meds, I just think there's this common phenomenon that you're seeing increasingly in medicine where they want you to try some drug first, knowing that it's not going to be nearly as good as something else because they're trying to maybe save a couple bucks, and it's not fair to people. Like, why make people suffer like that when there are better alternatives?
What happened to do no harm?
Yeah, no kidding. Yeah, I think that it's really important. I mean, I really try to make that a guiding light in my practice, really, at all times.
So let's go back to the ketamine and the work and all that type of stuff. And then you had said that there are some that can come from their therapist and straight to your clinic and do that. So the thing that I don't understand or know is, when person is in the drug, is this a talk therapy session? Is this just let the person lay there and meditate, or how does that go?
So people are utilizing ketamine in different ways.
Okay.
And that can include talk therapy kind of leading into the session.
Okay.
As well as like directly adjacent to the section, to the session. There's different philosophies about this. there are some, so yes, there are some people, and interestingly, that what they call, so there's psychedelic dosing of ketamine, where you might have visuals, you might feel like you're having a dissociative experience, an out-of-body experience. When you're in that kind of experience of ketamine, you're not going to be in a position really to talk and have a therapy session.
You're tripping.
You're tripping.
Yeah.
You are. Leading into it, though, especially, and on the tail end, there's something called psycholytic dosing of ketamine, which is this kind of, let's say, like a semi-trance-like state almost, where you're not totally in the medicine, you're not totally dissociating.
Okay.
But you're in a position where you're able to talk and able to communicate. And some people have found that to be very effective, like that they can kind of help kind of work through some of this trauma in that setting, and as well as directly adjacent to it. Now, there's another school of thought about using ketamine where frankly, there's, I mean, it's almost the opposite end of the spectrum, is this like pure medical model where they're literally just giving you an infusion and waving goodbye. That's not what we do. Our philosophy is frankly probably something in the middle, which is recognizing that, one, ketamine is a drug that causes neuroplasticity and neurogenesis.
Okay. Didn't know that.
And that is something that is so critical to how it works and why it's therapeutic. Because ketamine, like the thinking is that overall, most people, the reason why they have recurrent depression, anxiety, trauma, PTSD, so much of it is related to the fact that we keep looking at the world the same way over and over again. And we can't stop looking at it any other way. We just keep seeing it the same way over and over again. We ruminate, and it's constantly, that's all we can see. However, what ketamine does is that, I mean, and this is not like theoretical, okay? This is not like mumbo jumbo, like, oh, this is what we think is happening. Like, you can actually see pictures of neurons pre and post ketamine treatment. And you can see the synapses on these neurons, which are basically like opportunities for connections with other neurons. The synaptic density on neurons increases dramatically after a ketamine session. Like, basically, those are creating new connections in your brain. Those are literally physical new opportunities for you to see the world in a new way. So it's more than just something that's just like, oh, wow, it makes me feel good. It's like, no, it's actually like allowing you to see the world in a totally new way. But when you first come out of a ketamine session in particular, there's this pretty intense period of neurogenesis and neuroplasticity where the brain is literally functionally rewiring.
Okay.
So given that, our philosophy is that, like, that time around the ketamine experience is the time to maybe take a little step back, just make sure to kind of unpack what happened when you come out of the experience, but not necessarily the time for overt psychotherapy. But then the significant opportunity does exist in that 1 to 7 day period after the session, where maybe things have settled down a little bit. You started to develop these new connections, but then you can connect with the therapist and then help kind of interpret what happened during the ketamine session, what that means to your life, and how to apply it. So we work with many therapists in the community who send us clients, and we send clients back to them as well and say, yeah, we're here to kind of augment your care. We're here to kind of help enable further exploration and understanding of whatever issues may be with your clients.
And so you're saying that the ketamine makes physiological changes and it actually restructures the brain into some degree.
That's correct.
That's insane. I've heard a lot about stuff like the neurogenesis and stuff like that with other psychedelics like psilocybin. And I've heard that that's one of the things that it does is the neuroplasticity, and one of these things that helps. Real quick question about the ketamine itself. Is ketamine a fully synthetic drug, or is it like derived from something else?
That's a great question. Ketamine was first synthesized in the early 60s at Wayne State University in Detroit. It is an American product.
Okay.
It was first made here, and but it is actually naturally occurring, and we didn't find this out until just a few years ago. There's a fungus called Peconia chlamydosporia, which produces it naturally. That's not how we harvest it, but it's synthetically made. But I mean, by the way, ketamine, like a lot of people don't realize, ketamine is the most commonly used anesthetic worldwide. It is interesting. It is the most. It's been on the WHO's essential medicines list since 1985.
Oh wow!
There are parts of the world where there are no other anesthetic induction agents, and these are not like like far-flung place. I mean, we're talking like Australia, New Zealand, like this is all they use. Like they don't use anything else. Like America is honestly a little behind in how we use ketamine. We don't use ketamine as frequently as other countries do. In the hospital setting, we do, but not quite as frequently. Yeah.
I did not hear of ketamine being used ever. And again, when I was in, law enforcement, I'd go to the emergency room and have to get the list of drugs. What was, say this was a suspect, whatever. Ketamine was never used. It was never, ever, ever, ever used. And I didn't hear about it until ketamine clinics started becoming a thing. The only thing I'd ever had was there was training that there was a date rape drug called Special K, and it was ketamine, and that was literally it. Nothing about therapeutic effects, nothing about its actual medicine.
No, I was oblivious to it for years. Like I had no idea. I mean, these studies have been going on now since about the year 2000. Like,
see, something inevitably happens.
No worries.
Every time.
The data only keeps improving,
Sure.
and since about the year 2000, that's when a lot of the data about ketamine really started to come about. I mean, the EMS and fire world in particular, I mean, they're certainly familiar with it. I mean, it's something that's commonly used in ambulances, but honestly, to restrain people.
So at the paramedic level, they could use ketamine.
Yes, paramedics. I pretty much the entire country now has access. I mean, it's different. There was a pretty significant case that occurred in Colorado. It's called
Colorado.
The Elijah McClain case. A very, very unfortunate case. It received a very significant dose of ketamine beyond what was recommended, and it had multiple complications. Ended up passing away, unfortunately, and it was a terrible case. But since that time, they've tried to tighten up some procedures, and there are a lot of people who are like very anti-ketamine for anything. Frankly, there are better drugs than ketamine to restrain a patient.
Sure.
Not going to lie, there are better drugs, but they're just not as commonly used. And I think it ends up boiling down to the fact that ketamine is actually relatively inexpensive and now easy to find. Like there have been recent shortages, but finally it seems like the supply chain is now stabilizing out. And like I haven't had significant issues trying to obtain ketamine for the clinic, and probably in the past year haven't really having any issues. But I know there are a lot of people who still struggle just to find it, even in like traditional medical science. There was somebody I know in a pretty significant hospital system who reached out to me to try to help them get ketamine. Yeah, I mean, so there can be these issues. But back to what I was saying. Yes, I mean it is something that fire and EMS are definitely familiar with, and for good reason. It is an effective drug to do what it does, but yes, it must be used carefully.
Sure.
It has
like
to
any
be.
drug. Just
Absolutely.
like any drug.
And ketamine, look, ketamine's got a lot of baggage. Ketamine has a ton of baggage compared, like you said, Special K. I mean, like it has a history of recreational abuse, and appears to and will continue to be that way, frankly. I mean, when you use this drug though in a controlled and monitored setting, when it's used in a setting like our clinic, it is incredibly safe. You will not develop physiological addiction. You will not be in a position where there will be any real dangerous consequences of it. I mean, we've never had to send anybody to the hospital, knock on wood here, of course, but I mean, never had any issues with that. I mean, we do take the safety element very seriously. I mean, the other piece I forgot to mention too was just, making sure you have like adequate oxygen on site.
Sure.
Because yes, sometimes people's oxygen levels will go down. And then there's other occasional complications of ketamine. There's something called laryngospasm where your larynx will actually tighten up. I've only seen it once in the clinic, but I have seen it. And if you use ketamine enough, you will see it. Yeah.
Sure.
And that's where it's important to have a trained medical professional on site,
That would be considered a side effect though.
Yeah, it's very, very rare.
Gotcha.
We're talking, extremely rare. But all the more reason just to say that, I mean, this is something that is worthy of being used in a controlled and monitored setting. Yeah.
I am 100% on board for, again, my mindset having changed from being somewhat of a prohibitionist back in my law enforcement days to now, like, I would never trip on mushrooms just to trip on mushrooms. But at the same time, if you're telling me it has therapeutic benefits and there's research, let's go that route. Ketamine, I've never once considered using ketamine in a recreational way. I wouldn't even know where to have gotten it. But at the same time, if you're telling me there's therapeutic benefits, let's give it a try.
Yeah, and
let's have safe guardrails and licensed medical professionals there that know what they're doing and can save someone's life. God forbid something goes sideways.
And that's what it means to use it with intention.
Yeah.
You know, and that's where, like, you know, you look at what happened in this country with psychedelic medicines in like the 60s in particular. You know, Timothy Leary's doling out 1,000 doses of acid out of a punch bowl in Golden Gate Park.
Right.
Okay, and you're wondering, like, you know, these people are like, oh, people just got it wrong with these psychedelic medicine. It's like, no, dude, like, they were giving out massive amounts of these drugs in a completely reckless, like, largely unintentional fashion. You know, I mean, and look, I understand, like, I think using medication with psychedelic properties for the sake of personal wellness and personal growth, and even, you know, with the intention of mind expansion, so to speak, where, I mean, like we talked about, you know, creating these new neural pathways, looking at the world in a new way. Like, I think that's real. I think that's something that people should be allowed to do carefully, you know, as long as it's monitored. But yeah, I mean, I think that can be part of a personal growth product and a wellness product. I mean, you look at all these other products that people use for their own personal wellness and whatnot. I mean, all these different peptides and these weight loss drugs, testosterone, like, you know, injecting like things that might kill you into, you know, muscles in your face instead. You know, it's like, you know, they're doing all these different things, and it's like, well, wait, so you'll let people do that, but you're not going to let them have like ketamine, which can help them see the world in a totally different way and help them become a better person?
You'll
like,
drink that glass of wine or that bottle of whiskey that'll kill you faster than most of those things that you mentioned, but you won't let somebody try ketamine in a therapeutic setting?
Yeah, no, I totally agree. Or cannabis for that matter. I mean, this is nuts. Yeah, no, I mean, and I think this is an interesting day. This is an interesting day we're at right now, right? Because like this is an interesting moment that's about to happen, I think, politically,
yes,
and in the regulatory sphere related to psychedelics.
Amen. I agree.
And I have no idea how it's all going to look.
So that agreed. And I'm in the cannabis activism space. I'm the executive director for Arizona Normal, and I believe heavily in cannabis and its use. And you already nailed exactly what I say on a regular basis: with intention. My statement is always using cannabis with an intention and purpose. And I don't know what's going to happen politically, because this is my take real quick, that you have all of these veterans who are stepping in on the conservative Republican side that are really pushing for the ketamine therapy, the MDMA therapy, the psilocybin therapy, and all that. But at the same time, cannabis in and of itself is so stigmatized and regulated, and still a Schedule I drug.
Cannabis regulation is such a mess.
Amen.
It is such a mess. And it's like, it's sad. It's sad. It's like, it's so unbelievably confusing. I think it is a failure of government. I think there's just so many different levels that when you've created this like totally absurd regulatory tangle that, like, you know, they're probably like, you might be like one of the only people in Arizona who like knows how to actually figure it out. But like, I mean, there's so many different elements to it. Really. And it's like, it's so confusing. And, you know, people don't remember. They're like, wait, can the dispensaries, can they bank yet or no? Or like, can you take this on a plane or can you do that? Like, I don't know. There's just a million different questions that people have. And it's like, cannabis is a very benign drug. It is not harmless, just like ketamine, but it is an incredibly benign drug, and people should absolutely have access to it, especially if they need it. And yet another drug, obviously, that if used with intention can have significant benefits, very much so.
I want to talk about your personal experience on ketamine, if you would, in a minute. And I want to share just real quick one of my thoughts. I have not taken any sort of hallucinogenics before. I've had a very, 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 very tiny little experience with psilocybin, nothing of any therapeutic value. But what happened was, and again, I'll just make this very, very brief. I've told the story before. Back injury, out of law enforcement, started using cannabis to fill the gap because I didn't want to be taking, Percocets every single day and Advil or whatever the case is. When I started using cannabis, all of a sudden there's one experience where I had a mental breakthrough. I had some PTSD regarding a shooting that I investigated. And next thing you know, it's 1:00 in the morning and I'm standing in my kitchen crying and I'm reliving these experiences and I'm doing all this stuff. And it allowed me to disassociate from the trauma that had happened. And I was actually, this was now years later, and I was actually able to go through the scene and process it. And I want to say that regarding that incident, I could talk about it now. I've been to the site where this officer died, unfortunately, and I've been able to work all through that. And that was my breakthrough on the medicinal side of plant-based medicine. And that was the moment when I actually said to myself, like, oh shit, there's something to this. There's actually something to this. And understanding that ketamine is significantly more powerful. But it's the sort of thing where I had that one experience, that one time on cannabis with that particular event, and I never needed to go back through and relive that event ever again because I'm good now. I'm good. Like, I could talk about it now. I mean, again, it's still sad and all that type of stuff. How does ketamine work in that same sort of a situation, a traumatic event? Is it a one and done sort of thing, or is it something that you have to continue treatments with? How does that work?
So it's definitely different for different people. I don't think ketamine is ideally used as like a one and done drug. And I think the studies generally bear that out.
Okay.
I think ketamine ideally, the best study that was probably ever done on ketamine, there were a lot of great studies, but probably the most highly publicized study I think that came out was in June 2023, got published in the New England Journal. They compared 6 rounds of ketamine for treatment-resistant depression to what was always the gold standard for treatment-resistant depression, which most people don't realize, electroconvulsive therapy.
Oh.
Shock therapy. Like, a lot of people don't know that, but like, I've seen it. I saw it when I was in medical school too. I saw it at the VA. They're still doing it.
I didn't know that.
It has a lot of side effects, including amnesia and whatnot. But they compared 6 rounds of ketamine to a course of electroconvulsive therapy, and they found that ketamine was certainly non-inferior, meaning at least as good. And when you look at the data, it's pretty clear ketamine was better than ECT. It just, the study wasn't powered to show that, so to speak, but it's pretty clear that, yeah, ketamine outperformed ECT. I don't know why, barring any major contraindication, like, I don't know why anyone would choose ECT over ketamine at this point. No clue. Like, I have no idea why you'd say, I'd like to do the massive electrical shocks and seizures thing versus the, maybe I'll just try this drug instead in a safe and controlled and monitored setting. Now, but yes, it usually,
that seems a little wild to me.
Yeah, it is. But I mean, that's always been the gold standard. And it's interesting too, because I talked to medical students and, I asked them how they're learning about it. And it's starting to get out. I think they're starting to get taught that yes, ketamine is kind of the gold standard for this, for treatment-resistant depression, but they're still learning. And medicine is very cultural, and it takes a long time to watch things change in medicine. But yeah, ketamine, when you only have like one session of ketamine appears to be both what we call cumulative and durable. So like, it's cumulative in that it kind of stacks on itself.
Okay.
Like, the more you do, the greater of an effect that it has. But then it also, by doing that, it increases its durability.
Okay.
So it's kind of like, imagine you're like building up a mountain and it like, and then it just takes longer to ski off of that mountain. Let's say, like, the higher it is, it just takes longer to come down off of that mountain.
The gradient is a little bit longer.
Yes.
Okay.
And otherwise just one session, it's like, you just built like a little hill or something and then you're just come right off. So, one session though, for a lot of people, yeah, I mean, they might see, 2 weeks, 4 weeks, maybe even longer. It's just, and this just goes back to what I've seen in that it's like, look, people heal in different ways. And
absolutely.
And typically people in the clinic, they'll do 6 sessions, but after that, we've found that, yes, some people will want to come, well, we follow up with people, and we'll say, are you doing okay? I mean, we talk to people a year later and hear these wild stories. I got off 4 different psychiatric medications.
That's the goal.
And I haven't been on any. And you know what? I don't need to come back. And we're like, that's awesome. Keep doing you. If you need us, let us know. And then, we do have clients who have to come in once a month, once a quarter, and for to get like a booster of sorts, which is kind of a different way of looking at your antidepressant too, rather than, this like take it every day kind of a thing.
This trickle.
It's more like, using perhaps, an HIV prevention medication where you're going in for your monthly shot.
Sure.
And this is almost like taking your monthly antidepressant medication or anti-trauma or anti-anxiety medication. You just take it once a month, and like that's enough for a lot of people out there where they kind of boost themselves up. And that's very exciting. I love when people like find that kind of cadence where they're oh, I know I need to come in every 60 days and that's what keeps me afloat, or I need to come in every 6 months and that keeps me afloat. I think that is great. So that initial like more acute phase, the 6 sessions is definitely recommended. How frequently that's done. So we'll do it as frequently as 3 days in a row.
Okay.
Take a week off and then do another 3 days in a row. That's as frequently as we'll do it. As slowly as we'll do it. I mean, we work with people obviously, but we typically don't recommend any slower than like once a week.
Okay.
So we have a lot of working professionals. Obviously, we have people who will come in either Friday afternoon, or we have some evening appointments as well. So people will come in after work and do ketamine and then go about their business. And
are they like, once they're out of the drug? I guess would that be the proper term? Are you good to like go drive?
No.
Are you under? Okay, so so you need a babysitter.
So
And I apologize. It's just pure ignorance on my part. I've never been around anybody that's on it.
No, you're asking a great question. No, please, no. I think there's so much to learn about this.
And I want to know about the experience.
Yeah. No, absolutely, of course. We recommend that people do not drive. In fact, we don't allow people to drive.
Okay, good to know.
To and from the session.
Okay.
So a lot of people just get dropped off Uber, Waymo, or a friend. So they'll get dropped off at the clinic, and then somebody comes back to get them 3 hours later.
Gotcha.
So biologically, the drug is more or less, quote unquote, out of your system, let's say, at about 4 hours. So it really should not be exerting any physiologic effect upon you after 4 hours. Now, you still might have a little like fogginess, dizziness, headache, that kind of a thing that may extend for a day or so. But at the 4 hour mark, it's not biologically active. Beyond that, though, we typically recommend, ideally, especially for our first responders, by the way.
Right.
You ain't driving that fire truck for 24 hours afterwards, and they're very careful not to do that.
Good.
I mean, definitely not appropriate to operate any heavy machinery for that for the 24 hours afterwards.
No shooting guns.
No shooting guns. Thank you for mentioning that.
Yeah.
I know, no shooting guns, but yeah, I mean, we do have a lot of people who, for instance, like we have moms who come in. In a morning session, and then by the evening, they're, doing regular mom stuff. I mean,
right.
that kind of a thing. It's not like you can't do. It's not like you're gonna be unable to do your regular daily activities beyond that 4 hour period for like that whole 24 hours. Like you'll be fine, especially after that 4 hours. Like you'll be able
like
to go about your
ayahuasca
business.
where it's 12 hours or 24 hours or anything like that. Okay.
No, and I
Gotcha.
think a lot of that, with that timing, I think is one of the reasons why I think ketamine is very much here to stay. I think you can pack it more tightly into a regular lifestyle when you, whereas, psilocybin, MDMA, LSD, ibogaine, which lasts, 2 days even, that kind of a thing. I mean, psilocybin, obviously much smaller, usually like 4 to 6 hours, but
It's still wild.
But like it is still wild. And guess what? Like your day is over. If you do psilocybin, like call it a day. You're done. Okay.
Yes.
Like don't go back to working on spreadsheets in the evening. It ain't happening.
It'll be dragons and unicorns and, cheeseburgers.
Well, I mean, I think it is more of like, even when the so-called, the hallucinations and whatnot,
Sure.
when that dies down, I think it's still, there's elements that are still more difficult to kind of regroup on with some of those other drugs. But ketamine is a shorter experience.
Gotcha.
And that really does kind of change what happens afterwards. Yeah. Yeah.
Interesting. Yeah, no, that just, hopefully people who go and get their 30-day checkup, their 30-day boost, their booster, we'll call it a booster shot. I'm hoping that those people in those 30 days of feeling better, 60 days or 6 months, are starting to change their lifestyles as well. So they can start, helping themselves get out of the depression and all that type of stuff, which would lead to wellness.
And that's exactly what you're talking about, is exactly what phase 2 of this business is all about.
Okay.
Of this clinic. So recently brought on a well-known naturopath. Her name is Dr. Meredith Astrup. She is joining our team. She's our wellness director.
Okay.
And her goal is to continue that process of not just working through your illness or whatnot, but moving forward into that wellness.
Gotcha.
And what's so cool that I get to work with somebody like this, it's like I just recognize like how much I'm learning just watching her do her thing, and her knowledge base and how she kind of approaches these issues. It's just totally not something I'm familiar with, truthfully. So I'm learning a lot about that. But yeah, I mean, we're trying to extend the experience merely beyond just the ketamine's experience, but into this realm where we're trying to contribute to your overall holistic wellness. I think our guiding program is really essential to that as well. Our guides do a lot of the integration coaching, and that is ongoing. Our director of guiding, Alicia Malta, this woman is unbelievable. She is absolutely incredible. Very, very much in the, she's a nurse, was running the deep brain stimulation program at a department at a well-known hospital, let's say, for many, many years, and decided to kind of use a lot of those talents and bring them into the psychedelic space.
Nice.
And so it really focuses on the experiential aspects of the ketamine itself, but then also developing out this program that we're continuing to work on, whereas this ongoing integration. Yeah. And I think that's just so key. I think the ongoing integration may be the most important part of the entire experience. That's maybe where really the real healing occurs. It's like ketamine kind of cracks the nut, but then the ongoing stuff is what really helps people.
I mean, from a ER acute type of medicine, it's the broken, it's the femoral break or whatever, and the ketamine is putting it back together, and then the holistic healing is your physical therapy at the end.
I love that. Yes. Yeah, that's what it's like.
Getting you back as a whole person. And again, the older I've gotten, the more I've gotten into my health, and mental health comes first, or as first as I possibly can, because we don't having dealt with my own traumatic issues, you don't realize how worthless you are if you're not taking care of yourself mentally, spiritually, physically, and all that. And you have to take care of yourself first.
I couldn't agree with you more. And I think, by the way, that what you just brought up right there, where like how just, unproductive feeling you probably feel, which is obviously a stress to you. I mean,
sure.
But like looking at the other side of the coin about the employer, like imagine the employer here. Okay. Somebody with depression on average is missing 45 to 60 days of lost productivity every year. 45 to 60 days of lost productivity every year. When you compare the cost of ketamine to 45 to 60 days of lost productivity every year, it's a no-brainer.
Absolutely.
It's a no-brainer. Like, come on, like help these people get ketamine, which is why a lot of companies actually are starting to provide ketamine as an employee benefit. Like Dr. Bronner's did this whole pretty impressive study you can find online about the benefits that occurred as a result of making ketamine available to their employees.
What kind of a company was that?
Dr. Bronner's, they do soaps.
Okay.
They do soaps.
So a soap manufacturer provided ketamine treatments and probably saw his productivity
improve,
morale.
Employee morale, exactly, loyalty to the company, obviously. I mean, when you actually treat humans like humans, I mean, wow, it actually
concept.
works. People want to keep working for you. Yeah, it's like, it's something that's really positive. So yeah, I mean, that whole world to me is really, really fascinating. Like looking at it from that perspective of, it's like, hey, this is something like people people want to go back to work. Like they don't want to sit and feel like they're not being, not being productive, not being, contributing, not being able to, take care of their own families and all those things. I mean, it's more than just like there's a real calculus to the whole thing that's beyond just the therapeutic elements, which are obviously real and truly significant, frankly. Yeah.
How much better do you feel when you have purpose and you can go and do what it is that you want to do and you're not being held on to? And again, I will always go back to the first responder world of when I pick up, if somebody hops my fence and I pick up the phone and call 911, I want the most level, clear-headed, biggest, baddest stud to be able to come and take care of my problems, who's not thinking about the dead baby yesterday, but I want them in the moment. The same with the firefighters, the same with, your ER staff. I want them in the moment thinking about now and dealing with the trauma. And again, I fully recognize that your average individuals have their traumas and their sexual trauma in the past and physical trauma and all that. And I'm never negating any of that. Like my brain always just goes back to the combat soldiers, the law enforcement, the firefighters, the ER staff and all that. So I'm never negating someone's sexual trauma or whatever the trauma is in their past that they need to work through. Or like you said, obesity or depression or anxiety, whatever the case may be. My first thought is just always in that first responder type world, and how can we get them better to go out and do the best job as public servants?
Yeah. Yeah, no, I agree. And I'm glad you brought that up too. It's like, I think most people, when they hear PTSD, their first thought is the combat veteran.
Yep.
That's it, right? They're like, oh, that's for the combat vets, right? Like that's not for me. But actually the vast majority of people who suffer from PTSD, it is as a result of sexual trauma, as a result of physical assault, as a result of medical trauma. These are actually the things that are most commonly the causative agents of PTSD. And there's this, I mean, there's so much to unpack here with that. But yeah, I mean, I think a lot of people don't even know they have it.
Agreed.
I think a lot of people have no clue that they have it, or they're in denial. I think most people are aware of having experienced, trauma is something people, that word people are familiar with. And I try to say that word with people more like, have you experienced trauma? And I think that is something people can relate to a little bit more. But PTSD, they're not clear of like what that means.
Right. Well, I've never been shot at, or I've never killed anybody.
Right. Exactly. But yeah, I mean, there's so much of it out there, and there's a lot to be worked through. And I think that's where like MDMA is very exciting too, by the way. I think psilocybin is very exciting. I think truthfully, all these substances, there is a lot of overlap in terms of like what indications they work well for. And it's hard to say long-term what's going to be the gold standard for this indication or that indication. But, I mean, for trauma, for instance, MDMA, lots of great research coming out with MDMA. In August, the FDA panel reviewed MDMA, decided that we're not ready for it yet. I have mixed feelings about that, truthfully. I think it does deserve some more regulation overall. When you look at a lot of the MDMA studies, by the way, there were incidents of sexual abuse that occurred during the trials.
Well, that's just shitty.
It is just beyond belief shitty.
Yeah.
And it's like terrifying to think that in a study that was occurring. Like if we couldn't control that in a study, like how are we going to be controlling this in the real world? So I think bringing it back to the drawing table a little bit to try and kind of reevaluate some of those issues. There's a lot of technical issues with these studies in terms of blinding in particular. Blinding is always an issue because it's like, yeah, if you got the MDMA, you got the MDMA. Right. If you got the ketamine, you had the dissociative experience versus placebo. It's just like, it's not easy to control these studies. And I think a new standard of research has to accept that these studies will not look like other studies. And then if it looks good enough, and trust me, the MDMA trials look pretty damn good.
Yeah.
I mean, they look pretty damn good, and I am all for it. And trust me, I am right. When it is found to be safe, effective, and legal, I am 100% in. I want to be the first clinic in Arizona doing it. I want to make sure it's available to all the people who need it.
You're gonna have some competition on that. we spoke earlier about that. I won't mention names, but we do know that there is research that's attempting to happen here in the state of Arizona, at least on psilocybin. I think you nailed it, though, that it's different things for different issues. It's not a one size fits all. And having just done the tiny little bits of research that I have, it appears as though when you go into stuff like this, the typical normal double-blind placebo control groups and, peer-reviewed and all that doesn't mean much because there's nothing to back it up against. There is no gold standard, just as you said.
It's really tough. There are methodological issues with these studies that are inherent to them that you just cannot, people know if they got the drug. And
how far does anecdotal evidence go in studies like this? Unfortunately.
Anecdotal, so there's different level of evidence, and like anecdotal and expert opinion are very low,
right.
But those are the things that should trigger better studies.
Amen.
Right? There's
Amen.
You then proceed to retrospective analyses and prospective analyses, and then keep kind of going up the food chain, and then try to see what you can add in terms of blinding and what you can add in terms of randomizing and whatnot, and trying to get it closer to that gold standard of randomized double-blind placebo-controlled trial. But to get to that, which is really for a lot of scientists, they think that is the only way to actually demonstrate causation.
Right.
To get to you're just not going to get there with these drugs. You just have to accept it. But at some point, it's just dude, this looks like it's really helping people.
Yeah.
Why are we holding back on this stuff? And the reason to hold back on this stuff is if there's issues where it seems like it's unsafe. So if we're able to make it safe, then yeah, I'm all for it. Psilocybin is great. I think I'm very excited about the future with psilocybin. I am very concerned about the regulatory environment with psilocybin. I really worry that it's going to devolve into something that looks like cannabis.
Are you talking about as far as the federal government is going to be the only ones that grows really shitty weed? Out of the University of Mississippi?
I did not know that,
yeah.
But it doesn't surprise me at all.
So if you're familiar, the lawsuit that went through a couple of years ago was so that doctors could be able to do tests with better cannabis than the crap that the government was growing as far as cannabis goes. So would that be your concern that the federal government would be growing just terrible stuff?
So the psilocybin studies in particular, so much of it, many of the issues revolve around quality.
Okay.
You have to be able to get it to a point where you understand that you're providing a quality product, but also being able to provide a measured dose, of
sure.
We actually know, we are giving these people X number of milligrams. And therefore here, and then here is the associated effect. When you're giving somebody a whole mushroom, you just don't know. And you can get close. You're like, okay, I think this is going to have X number of milligrams of psilocybin in it, but the truth is you don't really know. So that's one issue. Now, granted, that's what Arizona had funding for whole mushroom psilocybin research. And got it approved, but it got slashed in the budget basically, so it never really made it.
I have a lot of my own thoughts on the Department of Health Services and their funding. That's for a whole different conversation.
That's part 2 of this podcast. We're coming back for that one another time. Okay. But regardless of that, as a substance, I think it's pretty clear that psilocybin does appear to have significant psychotherapeutic benefit for people. It is a very, very safe drug. And once again, ideally is being used in a controlled monitor setting. The bill that was written, the last iteration of the bill, which was, passed through the legislature, not super easily, but it made it through. I was in the committee room when the House voted on it,
nice.
And it was, everybody was, God, I think it was unanimous. It might have been unanimous.
I don't remember specifically.
It was, I mean, almost everybody was supportive of it
Yes.
from all walks of
Yes.
life, and they were all for it. It was very exciting. But then it made it to the governor's desk, and she vetoed it. And everybody's looking like, what the heck just happened? Like, how did this happen? And I mean, there that bill, written by Josh Moselle did an amazing job, and incredible job, ushering that through all the way through. I mean, I think that there will be another round. There's no doubt it's coming again. And I think there is a fair amount of public support, frankly.
Absolutely.
For psilocybin, very, very similar to cannabis, and I think, look, a lot of this stuff, it just takes time. Psilocybin is definitely coming, but it will be likely used in a similar psychedelic assisted psychotherapy treatment center where, where there are just more guardrails there available to people. And I think ultimately that's where we want to be, and not just doing guided sessions, which I hope that we'd be able to do guided psilocybin sessions, but also potentially doing psychedelic assisted psychotherapy where you have a psychotherapist with you at bedside while you're under the influence of the medication. Psilocybin's way more amenable to that than ketamine is. Same with MDMA. These substances are way more amenable to people talking while they're on the substance. They're not sedatives. They're not sedatives. Ketamine is a sedative. It's an anesthetic agent.
You're
it's
out.
like you're I mean, I tell people, like, one of the big differences between ketamine versus some of these other drugs, like ketamine versus some of the other psychedelics, is that ketamine is really much more of like an inward journey.
Okay.
And if done right, it's more like virtual reality, so to speak. So it's like with an eye mask and headphones on, it's much more immersive, internal. It's an exploration of the mind and consciousness. Psilocybin and MDMA, you're still interacting with the world.
Sure.
It just looks and feels a little bit differently, but you are able to interact with the world pretty effectively. So that kind of that sets it in a different zone, and I think that's where the psychedelic assisted psychotherapy component will probably have more value, I'd say. I think a lot of people do believe that, yes, ketamine also has value doing psychotherapy with it, and I think that's true. I think it does. But I think it'll have more readily apparent value with psilocybin and MDMA. Yeah.
Interesting. Again, just because you're just knocked out on ketamine.
Yeah.
So we're not talking, you're sleeping.
Exactly. Yeah.
I did speak with an individual who did, a law enforcement individual who did ketamine treatments. And he said that he was told, the biggest experience that he had is that he was told that the ketamine will give you what you need.
Yeah.
And again, not having personally experienced it, he was just giving me his thing and his experiences. And again, it sounds like an out-of-body experience a little bit. You're just not really, I don't know.
Yeah, no, you used the word dissociative earlier, which I thought was interesting, and that's something that can be a trauma response, there's obviously, like, we're familiar with like fight or flight, but there's also like, freeze, where people will freeze and dissociate. And that is a biologically functional thing that animals do.
Yep.
They'll be, some animal will be attacking another animal and they play dead, they act like they're dead and they're dissociating. And, that animal who's dissociating is one, like, allowing themselves to separate themselves from the traumatic experience that they're experiencing. And God forbid, if they do die and are mauled, then you have to believe that physiologically they're separating themselves from that response as well.
Right.
So I think that's where a lot of that comes from. But anyway, ketamine can produce that very similar dissociative experience. And I think it kind of begs the question about, like, allowing people to experience that dissociative experience, like, or re-experience that even potentially, like, how does that translate into working through your trauma? There's a lot of people doing what they call somatic experiencing out there, which is really fascinating. And truthfully, I'm learning a lot. I'm still learning about the psychological world a lot. And it seems to be something that allows people to kind of work and re-experience their trauma, especially people who have manifested that trauma physically in many ways, and I think most of us do manifest a lot of our psychological illness physically, but this kind of work in particular kind of helps kind of you complete the cycle and work through it further.
Trauma is stored in the body type thing.
Yeah, exactly.
I gotcha.
Yeah.
And again, in the whole body wellness sort of thing, I've learned that like different pressure points and pain in certain places and all that type of stuff is a direct response to traumatic events.
That stuff is real, man.
It is real.
It is real. And
You're
like
hearing it from a medical doctor that's saying this stuff is real. Like
it is absolutely real. Like what you're experiencing, like there is legitimate physical manifestation of psychological disease, period. Like it exists.
Amen.
And the quicker we get on board with that, the quicker we say to ourselves, wow, like what you're experiencing physically is real. And I mean, my biggest exposure to this is in the emergency department.
Sure.
I cannot tell you how many people come in for care in the emergency department because they have chest pain. And very common complaint in the emergency department, having chest pain, abdominal pain, headaches. So many of these people are merely manifesting their underlying psychological issues somatically in their body.
Okay.
Like they're manifesting it in their body. And then, yeah, when it gets so severe, they end up in the emergency department. Like I feel like, and I'm not exaggerating this, probably in my career, I wouldn't be surprised if something in the 40 to 50% range of the people I see in the emergency department are people manifesting their psychological illness physically. That high.
That's wild.
That high. And sometimes to the point where there actually is real damage. I mean, you have people who say that they were experiencing anxiety and they had chest pain, and you're like, it's just anxiety. But like, I've seen people have heart attacks.
Yeah.
I've seen people have actual heart attacks from experiencing that severe a degree of anxiety. I mean, like the stuff is like, you can really alter your body and cause harm to it with how you feel and with what you've experienced. Yeah.
That's why it's important to be intentional with what you consume, how you practice your daily life, try to be a little positive, try to show a little gratitude. I know this stuff sounds woo-woo, but it works.
I don't know if it does anymore. I mean, does it? Like...
You're right. The world is changing a little bit. That it's like, this is the stuff that I should be doing.
I feel like it is. And, I think this is, we're entering an unusual time. RFK, boy, I disagree with him on a ton of stuff.
Okay.
But one thing he and I don't disagree on is that psychedelics need to enter more of the mainstream. And I think he's potentially, I mean, I suspect he's going to get confirmed. Who the heck knows?
Right,
but
right.
I don't know what's going to happen with the world of psychedelics, but I think it's fair to say that this could be a watershed moment for these medicines over the next few years, and I'm here for it.
Yeah, it's definitely going to be interesting.
Yeah, who knows?
The thing that I had mentioned before that it annoys me is that you have your traditional mental health medicines. I'm not a doctor, so I'm not specifics on them. Your SSRIs and all that type of stuff. And then you have cannabis kind of in a class of its own. And then you have these other, like you said, the psilocybin, the MDMA, ketamine, and all sorts of things. And the thing that I've been upset about is that there has been a push from conservative Republicans. I am personally politically a conservative Republican, okay, but I'm also in the cannabis space as well. So some people don't know how that goes. From conservative Republicans that are military veterans are on the big push for the ketamine and all that type of stuff. Mm-hmm. And my personal complaint is that they're missing and skipping over cannabis.
Yeah.
They're not talking about it. There are some people, correct me if I'm wrong, I feel as though there's some people that are just not ready for a ketamine trip or just not ready for a MDMA trip.
Absolutely. No, I couldn't agree more. And I think, cannabis has clear benefits for some people.
Sure.
Yeah. I mean, just like, and I think that's fair to say about all these substances, really. Right, I mean, It's like there are clear benefits for some people. I think cannabis is kind of a fascinating drug, and I think we're still learning a lot more about it. it seems to be hit or miss for truthfully. You know, it's like it really works for some people and it really doesn't for others.
Yeah. Yeah.
Like anxiety, for instance, acute anxiety, you take cannabis, a lot of people, it's like they can chill out. Yeah, but then there's some people who are like, they get that whole paranoia thing and they start, you know, they're freaking out. And so, yeah, I mean, it can go either way.
Yeah.
But at the same time, that merely says like, okay, you know, one, using it with intention, like, you know, will give you a sense of whether or not, like, if you're not using it with intention, I mean, whatever, which is a whole other discussion. Like, obviously, I don't have any problem with people using cannabis recreationally, period. But if you are using it with intention, and especially for something like anxiety or depression, like, really be aware of how it's affecting you. You know, really take note of how it's affecting you. With like anxiety in particular, like, I think you can tell pretty quick. You know, it's like, this is chilling me out, or nope, this is driving me up a wall. Like, it's going to be, and even veteran cannabis users can experience both, right? Like even veteran cannabis users can be like, okay, yeah, that kind of stuff made me feel that way. That kind of stuff, I'm going to stay away from that.
Yes.
And like acknowledging that and being careful with that. I mean, yeah, that's pretty effective. You know, depression with cannabis. You know, I was just talking about this the other day with a local psychologist who just what they had seen in their practice with people who are heavy cannabis users. And it's the same thing. They were like, you know, some people it seems to work great, and other people it just doesn't. And it may make it worse even for some people. For pain, yeah, cannabis is great.
Amen.
For trauma, yeah, I mean, I think it can be a little hit or miss. I mean, it's not like, you know, probably like the first drug I'd necessarily reach for.
Agreed.
But it's the same thing. I think like it's definitely in the armamentarium. There is no doubt about that. And people who are missing it, you know, I still practice in the emergency department, by the way. I still work part-time in the ER. And when I see patient, like I've seen patients like end stage terminal oncology patients who are asking me if they think if it's okay that, I mean, they're on like fentanyl patches and morphine this and Ativan that. And they're asking me like, do you think it's okay for me to use cannabis? And I'm just thinking, I cannot believe no one up until now has said to you, why don't you go to the dispensary and get yourself some cannabis? Like, you haven't been eating in days, like you're in miserable pain. Like, my goodness. Like, and that whole world, by the way, the world of hospice and palliative care, that whole world is going to be upended by psychedelics, period.
You think so?
Absolutely. It will be upended by psychedelics. Personally, I actually think ketamine is the drug of choice.
Okay.
In the hospice and palliative care world. Tell me another drug that helps treat anxiety, depression, deals with existential crises, and treats pain. There is no other drug that does that except ketamine.
Okay. Yeah. So on the existential crisis front, and I've heard that people who have used psilocybin have come to terms with their own deaths.
Yes.
Is that what you're kind of explaining?
Yes.
Okay.
But what psilocybin's missing is pain. It doesn't treat pain.
Didn't know that. Gotcha.
So, but yes, psilocybin does appear to be a...
Shit. My camera just overheated. Let's take 5 minutes.
Okay.
Every 2 weeks. The hardest part is the editing. The hardest part is, again, I want it to look good. So when you're talking, I want the camera to be pointing at you. When I'm talking, I want it to point at me. Well, all that takes integrating it all into the software. And then, don't get me wrong, I'm enjoying the conversation, but I also don't want to go back and just listen to it simply to change the cameras, but I have to.
Yeah, no,
so
it's annoying.
It makes it just a little,
Totally.
it's boring and monotonous where it's like, so when you're talking, I have to hit the button, and then when I'm talking, but I also figured out a way to speed it up. So that's the hardest part is the editing.
Oh, and the most just like boring and not fun part,
Exactly.
obviously. Yeah.
And the other part is, though, too, like I said, I want to integrate other things into the podcast. So I want to come down and take some video and all that
definitely
stuff.
would love to show you around the
That'd
clinic,
be awesome.
of course. Yeah,
That'd be awesome.
I'm really proud of it. Like it does not look like anywhere. It's not what you think it is. Like it just isn't. Like you'll see it and you'll say, wow, like this looks like nothing I've ever seen before. Yeah.
All right, make sure we're good to go. We're back on. And again, my freaking camera's overheated, and it happens every once in a while. Okay, so what we left off on was dealing with existential crises.
Yes.
So continue.
Yeah, no, dealing with existential crises, of like the death and dying process where people are asking themselves, or existential crisis in general, who am I? What have I done with my life? What matters, if anything? Those kind of like outlying questions, especially, and obviously for a lot of people that comes up at the end of life.
I'm sure.
Those kind of things, like did I lead a good life? I mean, that's a really serious question. Like what should I have done differently? So yes, there is some great research that's come out regarding psilocybin for end of life care. And I think that psilocybin will ultimately, just one dose even, enhancing the ability to navigate the existential crises of the dying process. Psilocybin will invariably enter that space eventually when people loosen up a little bit about it, but ketamine, I think, is already there and is being heavily underutilized in that space. But yeah, I think ultimately death won't look anything like it does right now. The dying process, I think, will look very different. Would not surprise me at all within the next 20 years that psychedelics are incorporated into the world of hospice and palliative care. And part of that, and I've done a really deep dive into these worlds. Like these are absolutely fascinating. The worlds of hospice and palliative care. Hospice is like so mechanized.
Okay.
It's like, it's just very specific what the rules are and how it's paid for. And
say it's because of insurance purposes.
Medicare dominates hospice.
Gotcha.
And if you're not on Medicare and you're on hospice, you're on your way to Medicare.
Gotcha.
Like everybody ends up on Medicare. Arizona has a very high hospice utilization rate, by the way. Arizona's hospice utilization rate is among the highest in the country. It's about 55%. Over half of people in Arizona will die on hospice.
Wow, that's a huge business.
It's massive. There are over 300 hospices in Arizona alone. So there are a lot of people in this space. And yes, Medicare is the real primary payer in the space, and they dictate the rules. And some of those rules come back to the fact that you can't be admitted to the hospital. If you're on hospice, like you're not supposed to be admitted to the hospital if you have a major medical issue. If it's something that can be addressed in the emergency department, which often we do, we'd make some tweaks and whatnot, send people back out. That's fine. But once you get admitted to a hospital, the rules change again, and then you might not be on hospice at all anymore. And it's just totally different. But the palliative care is a mixed bag of several things. But one of the things it is like pre-hospice. So hospice, by the way, is a definition that a doctor has declared you that within the next 6 months, without any medical intervention, you will likely be dead.
Okay.
Palliative care often is almost like pre-hospice.
Okay.
It doesn't have to be. It can be merely pain control and palliation for non-terminal diseases potentially, but for the most part, it ends up being this kind of like pre-hospice phase.
Sure.
And that world is like completely unregulated. Like nobody knows. Like you ask somebody what palliative care is, and it's like they can try and give you a definition, and they will, but like truth be told, like how it all looks in the community, it's just like all over the map. But I'll tell you this, one thing I have learned is that most people in the palliative care business or in that pre-palliative space, I guess, I mean, pre-hospice space, forgive me. If they're in that pre-hospice space, basically they look at that palliative care space as being like the road to hospice. And the pathway to get to hospice it involves a waypoint where the patient decides that they are ready to die, that they're ready to move on to that next phase. And part of that can often be deciding to be what we call DNR, DNI, do not resuscitate, do not intubate. You don't want any of these major heroic interventions. at the end of your life, and making that decision. I personally believe that if you are able to better confront the existential crises of the dying process, that you will be much more likely to end up making that transition to hospice. Median life expectancy of hospice right now, 18 days.
Oh, wow.
18 days. That means like the middle person, 18 days later will be dead, who ends up on hospice. But it's actually, when you look at the numbers, it's actually a bimodal distribution. There's like two different distributions. One is people who are dying in like 2, 3, 4 days.
Gotcha.
And there's a lot of them out there.
Meaning that they just found out and they've only got a few more days and they're moving to hospice?
No, they decided too late.
Gotcha.
They decided too late.
Gotcha.
And they, I mean, they say you ideally should start hospice 6 months in advance of dying. I mean, we obviously, if we can seldom time it that explicitly, but if you have a good idea that you have 6 months left to die, and if you're ready to traverse that next period, your last period of your life, then yeah, it can look different. It doesn't have to look like people in and out of the hospital with like tubes, lines, procedures, whatever.
Right.
I mean, and that stuff is, I just cannot believe how much medical consumption there is at the end of life. And it really needs to look different. And like that's just where I know psychedelics can play a positive role, where people can have a death that has a lot more dignity involved. A lot more comfortable, and something that everybody can reconcile with. Yeah. So I think the emergence of psychedelics in that space, and there is a really great organization called the EOLPC, End of Life Psychedelic Care. They're deeply involved in this space and trying to kind of get the word out and work more in this sphere. I had started a side business of sorts called Sunset Ketamine, where we were actually going out to people's homes and administering ketamine to them in home for patients who are on hospice and palliative care. Unbelievable results, like just absolutely flabbergasting results.
What does the good results look like? So they're in palliative care, you come out to their house, and now you've given them their infusion. What is their mindset change?
They're able to confront the reality that they might be already in the dying process. They're ready for that. But it can also function as a pain reliever, and it can just be an experience. I mean, my God, like
I have no problem with that.
These people, I mean, look, you might not have the funds or the capabilities or the mobility to go to Paris one last time, but you may have the time and the energy to take a journey into the mind and a journey into consciousness. Maybe you have that ability. Maybe now's the moment to do it towards the end of life. And I think that's very exciting. It's very, very exciting to me. And I've helped a lot of people die. And I take it very seriously. It's something that's very important to me. I want everybody to have a death with dignity. I think everybody wants that in their lives, and they want to see that for their family and friends. And I think psychedelics are a pathway to greater dignity in that world.
Those are powerful words. Those are very powerful words. That was just an eloquent way that you said what your last statement that you just said. You obviously take it to heart. For those that are on the fence and don't know where to go, what to do, is this the next step? What's the next step for them to see if this is something that they want to try? If ketamine is in their future.
Yeah, I mean, so you can self-refer. People,
Okay.
If you feel like you need ketamine, especially for depression, anxiety, PTSD, OCD, trauma, eating disorders, any of the above, just reach out to us. Yeah, and we can figure it out. And that goes for most ketamine clinics, frankly. People can self-refer. I always do like it when I can connect all the dots with people, with their practitioners around them. If I can work adjacent to a therapist, or if I can work adjacent to whatever doctor may be involved with their care, that's the preferred way to do it. So we definitely do take many referrals. We take a lot of referrals from providers in the community who say, yeah, I think this patient of mine needs your help. And I say, well, let's see what we can do to kind of help augment your care. and we do that. But I mean, I think first and foremost, taking a look at the website, seeing what it's all about, maybe learning a little bit more. I mean, we obviously went over a fair number of things here today, but it's always good, more information. But the easiest thing to do is to just go on the website if people are interested and just put your information in, and we'll reach out to you within a day and we'll figure out whether it's right for you. I'd say this, the major contraindications, the ones where we really can't give ketamine for, one, a history of schizophrenia or psychosis.
Okay.
Two, history of active pregnancy.
Okay.
Not breastfeeding, by the way. In fact, postpartum patients who have that is something we can definitely do. We just pump and dump for 24 hours breast milk, so that's okay if you're in the postpartum period breastfeeding. And then the other one really that's tough to get around is uncontrolled hypertension. Like if people have uncontrolled high blood pressure, but that's something a lot of the time, we can get managed beforehand. We do get some clients who come in, they're really anxious when they first come in, their blood pressure's high. Most of the time, with some breath work and meditation leading into that, during that preparation phase, we can get their blood pressure down, but we do have medications on site that can kind of temporarily lower your blood pressure if needed as well. But really, I think, it's the schizophrenia / psychosis as well as pregnancy that those are the ones we just really can't do. And there's a lot of other, relative contraindications that we just have to sort out. But that's what the medical intake process is for.
Right. Yeah. As any professional medical clinic, you're going to get the full history and all that.
We do, by the way, we do also do some work with adolescents. We work with 13 plus.
I never heard of that.
So we'll work with teenagers. We'll do teenagers. Once again, really you have to make sure they have like adequate wraparound care and make sure everybody's kind of on board with moving forward in that case. But I mean, we've had pretty significant success, frankly, with people. As the youngest we've treated is actually 14. We've had a few 14-year-olds, but really incredible. And the teenage population, especially now with like how disconnected we've all become.
Right.
I just get so concerned about these young people and how capricious they can be. They have a bad day. They broke up with their girlfriend and they come home and they decide that's the day.
Yep.
And that just scares me. That scares me.
We're not teaching very good coping skills.
No, we're not. We're making, I think in a lot of ways things are kind of too easy.
It's this damn thing.
You got it. Yeah. It's just too easy.
Damn thing.
When you're constantly having... When the so-called quote unquote challenges in your life are so easy that you can just grab your phone and fix them, like, how do you know how to confront real challenges in your life? We're taking that away from people, like real learning how to deal with struggle. And I think that whole world of like, kind of like microaggressions and whatnot and everything, it's like, that may look like trauma, but I'm sorry, like sometimes you got to work through some stuff on your own. Okay?
Not everybody's going to be nice to you.
Like you got to try, like there are real struggles out there and like, taking a test is not trauma. I'm sorry. It's just like, look, you're these are like the basic steps of life of like things that you have to learn how to cope with and deal with yourself. I think we have a lot to learn, and I'm really scared about what the phone does to people long term.
Yep.
I've got 2 boys, I got 2 young boys, and I want to make sure I'm doing my best on their behalf and trying to give them as much digital hygiene as we can. Because I think the ramifications are enormous and long-term community-wide psychological implications could be long-lasting and truly problematic.
And there's so much vulnerability on the internet. And again, my previous guest that I had on, hunted predators that were preying on our children online. And it's just like, it's so unsafe. There's a way to navigate it. But again, when it comes to the mental health aspect of it, they have everything that they want in the palm of their hands. They're not being challenged in anything in any way, shape, or form. And then they can't deal with a little bit of challenge and adversity in life. So
it's scary. It's scary.
It is scary.
Yeah.
We have covered a ton. I am sincerely appreciative of your time. And I'm going to go down to the clinic. I'm going to take some video and put it out there and integrate it into this so they could see like the whole experience. And I'm interested in the whole experience and to see what it looks like.
Yeah, no, can't wait to have you down at the clinic. Absolutely. Awesome. Love to show you around.
What's the address?
It is 3601 North 44th Street.
Okay.
Phoenix 85018. So we're in the Arcadia neighborhood. We're about 44th Street in Osborne. So a lot of people use 44th Street to go to the airport and whatnot. So a lot of visibility there. But yeah.
So where can they learn more about you and the website? And what's the website?
So yeah, the website is Kadelyx.com, Kadelyx.com. And you can definitely learn about all our different services. There are a lot more stuff than just regular one individual ketamine sessions. We do couples ketamine work. We do group ketamine sessions. We're trying to do really all forms of ketamine that appear to be effective. So yeah, we're going to do it all at the clinic. It's very exciting.
Very cool.
Yeah.
Well, thank you again so much for your time. Said we'll get this out there soon, show the clinic and all that good stuff, and get some more feedback on it.
Hey, thanks so much for having me, AJ. This is great.
Thank you.
Appreciate it.
Perfect.